So, regarding the clinical application, I have brought here what we usually do is different issues. The first of all is a specific assessment protocol. So, when you are evaluating trigger points, we know a lot of criteria. So, for us it's very important the clinical interview with the patient, the physical examination, so including functional tests, and also some analytical tests that was designed for these neuro patients, and finally when we can palpate or feel through the needle the trigger point. Okay? So for example, I'm going to put here a video. This is one of the tests we designed for assessing the neurological patient. Sometimes as a physical therapist I have problems to be sure that I'm in the trigger point, that I'm in the flexor digitorum, for example. So sometimes with a pointer or with something I can be checking if with the minimal amount of current I can be in the muscle I want to treat to make fast in, fast out technique. So apart from this specific assessment protocol, we are going to make a comparison of the diagnostic criteria. So, as Lynn has explained about some of the essential criteria, we know that one of the criteria is that we can select within the thought bands that one that has the most degree of tension. And one important thing for me, because it's very tricky for me, is that when I think about the definition of trigger point, it doesn't make a lot of sense for me, because from a clinical point of view it's clear that you say, okay, there is a tender spot or tender nodule in a thought band, so it's a very good criteria. But if we want to define a trigger point, and these are trigger points in the neuro patients, I don't find pain at all. So I should define the trigger points in another way, because I should characterize the tissue or saying what is really a trigger point independently of the clinical evaluation. So for me, in my experience, the most important thing is to feel a nodular area and increase in the volume, some heterogeneity when you are palpating, and this is supported by recent studies by this research team that there was a statistic significant difference when you find an increase in the area of the trigger point. So for me, if I find these nodular areas, this increase in volume, this is sometimes saying, okay, there is a dysfunction, so this is a trigger point for neuro patients, because if I ask them, they don't have pain at all, and they can differentiate if any point is more tender than the other. Apart from that, it's very important to feel or to evaluate the movement and the function of the patient. So as a first approach, we can have a look, as in the previous video, okay, which are the main difficulties for this patient. So after that, we are moving to analytical tests, and we are going to check our hypothesis to say, okay, this muscle could be shortened, or this muscle can be overactive. So more or less we can be through some hypothesis to say, okay, for us the most important muscles to treat should be this, so we can prioritize which muscles are more relevant for every patient. And another criteria essential for us is to perform some clinical tests stretching the muscle at different speeds. So if we can see that there is a high central component, there will be some kind of catch, and we can reevaluate and realize if this catch is decreasing, so the myotactic reflex threshold is increased through treatment. So regarding the confirmatory diagnostic criteria, I also use the local twitch response as a gold standard, but sometimes, it's not so often, we can find some global twitch responses. So if you find them, both of them, the local twitch response or the global twitch response, can be related or are correlated with the clinical effectiveness. So when we just achieve this local twitch response or the global twitch response, what we usually see, as you watch in the video, is that there is a contraction release. So this is a sustained relaxation that for example, it's telling us that we can stop the treatment and apply dry needling to other muscle. So sometimes as a clinician, when I'm treating patients with myofascial pain, my question is, okay, when do I stop doing this dry needling? When the frequency of local twist responses decrease, when they disappear, sometimes they never disappear, so the patient says, okay, you just can stop, okay? But in this case, sometimes if I even get one local twist response, I'm going to feel relaxation, so this is a good clinical guide for me because it says, okay, I have achieved the effect, so I can move to another muscle. So in neuro patients, sometimes we do a short treatment for every muscle, but in multiple points to make a big effect. Another confirmatory criteria, if we were in a laboratory, would be the EMG, but in a clinical setting is not so relevant. So, apart from the criteria to diagnose, another thing important is the methodology and how we apply the procedures. So, there is a big difference when you compare with your knowledge about treating myofascial trigger points in pain. And the main difference for me is that we should place the muscle in a submaximal stretch position, although with some exceptions. Because if we are in a musculoskeletal patient with pain, we have to treat in the mid position more or less because sometimes stretching is going to be painful. But if we move to neuro patients, what we realize is that it's very difficult to feel anything, or to feel a thought band, to feel a nodule, to feel an increase of resistance when they are in a shortened position. So if we move them to a submaximal stretch position, this is a position where they are going to be a bit more relaxed. So on the one hand, we can feel that some vectors or some thought bands are going to be maintained, and in these thought bands it will be easier to feel some nodules in it. Okay, so this is one of the reasons, and the other is that if we are in a submaximal stretch position, we are going to feel a lot of resistance. So if we are effective, we are just going to be aware that we are being effective. So this is another reason. So because of these two reasons, I can recommend to doing submaximal stretch position, although I would like to highlight some exceptions. For example, if a muscle can be very precisely dry needle with a pincer grip, you just choose this option, and it's not necessary to put in so stretch, because sometimes it's very difficult to make a grip if the muscle is very stretched. Or, for example, in some places like the thorax where some movement can occur, if you want to increase the safety of the technique, perhaps this is also a good option to make in a more mid position. Or sometimes if you are not treating an overreactive muscle, you are treating to improve this weakness, you don't need to do this. So these are some of the changes we are applying in the clinical setting. So one, we have placed the muscle in a submaximal stretch position. An important thing is to control the segments, because sometimes spontaneous movements or abrupt movements occur, so we have to be aware not to get any punctures. Okay? I was doing a joke yesterday, and I was saying that when you start dry needling, you are so scary that you never have any punctures, but as you are getting confident, sometimes you have some problems, because you are very confident, say, okay, I control this, and sometimes I have some problems. So don't forget to take all the care, because you never know when the patient can move, so it's necessary to stabilize. And then when we are stabilizing the patient, we try to look for these local twist responses until we feel a clear relaxation of the muscle. But sometimes this relaxation can be easily to feel, for example, through our feeling, the palpation of the resistance, but sometimes there is an indirect component, which is through the needle. So sometimes when we insert the needle, we can realize how the resistance for inserting the needle is decreasing. So this is also one indicator that you can be having a good effect. Sometimes what we do is to maintain for a time if there is a contraction, but Then we remove the needle, but not out from the skin. So sometimes what we do is we put the needle, we take to the skin, we move a little more, and we follow with the treatment. So this is up to you to do like this. For us, it's important to respect about 7 days to allow reparation of the tissue, as you know. And our experience is that the first session has a peak effect, as in other treatments, and sometimes in 3-4 a week it can last, but it depends a lot on several components, biological components, functional components of the patient, concomitant treatments, so we can say clearly which is the effects, but we can say, supported by the studies, that it's going to have a peak effect of 2-3 days, and then it's going to decrease. Okay. So depending on where we are working, we do research protocols, very standardized, or just we apply by objectives like in a clinical setting. So an important thing for me, because there are always people that misunderstand this, is that we have to integrate dry needling with the rest of the technique. So we consider dry needling like opening a therapeutic window, and then we can do cognitive treatment, functional treatments, anything you know, because it's allowing us to work better. So if some physios are understanding that botulinum toxin can be injected, I think that they should be understanding that dry needling is an option, especially for physios, because in most of the countries we are not allowed to injectate. And I think that it's not just a question of the amount of effect, it's just a question of that sometimes perhaps I need much more treatments for getting the same results than botulinum toxin, but on the other hand, there are some patients that if we inject a botulinum toxin and we get overdoses, they can be very restricted. So imagine a patient that can only move the finger like this to communicate. We infiltrate a botulinum toxin injection, and then he spends 2 months without being able to recruit. So in my mind, the dry needling allows to give like micro doses of treatment, so we don't have the risk to give overdoses, although we have to compare protocols, for example, with 1 infiltration and I imagine 7 dry needling treatments, because we don't work the same way than, for example, medical doctors' infiltration. So I think these new studies should consider this, and in the case of a study we are developing now, we were comparing 1 injection of botulinum toxin and 7 treatments with dry needling, and we are comparing the cost effectiveness of both treatments, because we think that we should compare real things like physios are working at the moment. Okay?